So welcome to day 2 of our workshop. This morning we have 2 sessions. The first session will be on screening and early detection in low resource settings. We have 3 speakers, Dr. Samir Khleif, Isabel Skorinsky, and Peter Kingham. And this will be followed by questions after their talks. And then we'll end the workshop this morning with a panel of stakeholders to get their perspectives. So our first speaker this morning is Dr. Samir Khleif. He's the director of the Georgia Health Sciences University Cancer Center, where he oversees their clinical operations as well as research. He's a cancer vaccine expert and previously served as the chief of the NCI's cancer vaccine section. And in addition, from 2002 to 2006, Dr. Khleif served as the director and CEO of the King Hussein Cancer Center in Amman, Jordan, which under his leadership became the first internationally recognized comprehensive cancer center in the Middle East. So welcome, Dr. Khleif.
So just out of interest from my introduction, I think the bio that you got was probably 3 months old because our university changed name now 3 times since then. Okay, so I'm going to basically give a talk about Jordan versus Georgia and try to give some thoughts about particularly an area of beliefs and culture that would affect a lot of what we do with screening and early detection in low or middle income resource countries. So Jordan is a country in the Middle East. Just to give you a background, population is around 6.5 million, with increase in 2.2 annually. It's a largely urban population of 83% are in cities. And GDP per capita is around $3,000 in 2014, has lots of challenges, including poverty and unemployment, including insufficient natural resources, particularly water, no oil in Jordan, inflation, and finally, the last one is refugees. Jordan is a country, as I mentioned, of 6.5 million, and now they have 2 million refugees within the country. So that would actually not only affect the resources on healthcare, but anything that is relevant to planning. The other challenge in a country like Jordan is that it has its pyramid population, and majority of the population are under the age of 35. So when we talk about cancer, their planning purposes, particularly prevention and early detection, is going to be a major area of emphasis for a country like that, particularly when there is planning for the next 10 to 20 years, because majority of those people are going to be old and are going to be developing cancer. With the help of the National Cancer Institute, Jordan started a registry in 1996, and these are the number of the registries, almost 4.6 or 4,600 cancer cases per year. But again, from non-Jordanian, there's 2,200, and that also reflects a lot about the refugees and what exists in that country. The 1995 surge in cancer to 1996 is because the registry was started, not because if there was any nuclear bomb or something. The top 5 cancers are breast, colorectal, and lung, plus cancers that are lymphoma and leukemia, which is more than majority of these numbers, particularly lymphoma and leukemias, are more than the Western world. And leading causes of death from cancer in males are mainly lung and colon, and in females are mainly breast and colon. So there's lots of room for early detection and prevention. If we look at the incidences in male, it's lung and colorectal, then followed by bladder and prostate. In females are breast and colorectal, which reflects, of course, the incidence of mortality. And then thyroid is pretty high in female, and uterus. And this is based on the registry in 2011. So in 2002, NCI developed an agreement with the government of Jordan to help develop a cancer center within the country that is later was called the King Hussein Cancer Center. and I was actually seconded to Jordan to help in the development of this cancer center. The interesting part in Jordan is that Jordan at that time, and it still is one of the most advanced countries in the Middle East and probably in the third world in their healthcare and healthcare system. As a matter of fact, Jordan is a place where health tourism forms almost 50% of the tourism of the country that has a lot of touristic attractions. So almost 7 or 8 countries around that area refer patients to Jordan. Despite that fact, when actually we went there in the early 2000s, 2002, 2003, lots of indicators actually did not match that. If you look at smoking, almost 70, and this is a survey that was done at that time, almost 70% of males and 20% of females above the age of 18 smoked at that time, at least in the last 3 months of that survey. Worse yet, 10 to 15% of kids between the age of 13 and 15 also smoked. Now, the other interesting part, again, despite the advances in healthcare in that country, majority of female discovered breast cancer in stage 3 and 4. It's more than almost 70% of cancer that was discovered there was around that period of time was stage 3 and 4, which was pretty advanced for a country like this. Now, when we think of those areas, and particularly in late discovery of cancers, particularly in breast, we were actually shocked in the amount of not only lack of awareness, but cultural force that lead to this particular problem. First of all, the word cancer was not even uttered in the country in the 2002 and 2003. So when we started talking to people about cancer, this word was actually not only a taboo, but it was looked upon anyone that talks or mentioned that word as against society. It's something that should not be mentioned at all. As a matter of fact, the cancer center that we took over was called Al Amal Center, which is the Hope Center, and 70% or 75% of patients that were in that center at that time did not know that they had cancer. They thought they had either inflammation or some other disease that they come to be treated for. So when we think of even thinking of prevention and early detection, with the inability to mention the word cancer, that would have been a major impediment, not only to talk about it, not only to tell people not to smoke, but let alone to start thinking of, well, you need to do screening, or you need to start a national program for mammography or for anything to that matter. As a matter of fact, lots of patients we used to see at that time, they do come with breast mass of almost 3 centimeters, a golf ball breast mass, and you talk to the woman and says, how long has it been there? It's been there for 2 to 3 years. Why didn't you come? Well, I'm afraid that it's cancer. So, well, it is cancer, and this is a major impediment for us for anything that we wanted to do. Cancer is contagious. That was an overwhelming thought. If you have cancer, like I remember the first or second day I was there, probably maybe first week, I had a visitor who was the most prominent journalist in the country that came to have an interview in the eminent newspaper, daily newspaper, and he came to my office in that building, putting his hand on his nose, and I said, "What's happening?" He said, "Well, I know it's contagious, so I don't want to breathe the air," and that's one of the most prominent journalists. Actually, he was even a health journalist, but so when we think about this, the amount of lack of knowledge and misconceptions were amazing. It made me ashamed. It's a stigma, and it's a major stigma. So when you think about a stigma and when you think about a monster that you don't know anything about, it's really very difficult to even start talking about what you can do for early detection and prevention. So the impediments were, one, stigmatization, second, lack of knowledge, and then there are four others that we'll talk about them in a second. One is society structure, social restrictions, religious beliefs, and governance. So when we talk about stigmatization and lack of knowledge, a survey that we've done when we were there, looking into almost 3,200 Jordanian randomly selected, lots of those people really believe that, one, that envy and witchcraft could lead to cancer, and second, that cancer exposure to other people with cancer would lead to cancer, and that there's no cure. So if you take those three into account, why would I even think of having an early detection attempt? Because if I know I have cancer, no one's going to talk to me. If I know I have cancer, no one's going to come and visit me. And if I know I have cancer, people are going to be thinking that I got a devil or some bad thing that would be of absolute shame. And finally, if there's no cure, why would I even bother? And that was one of the major issues. One thing in that survey that we found, that people thought that cell phone caused cancer. 83% of people thought that cell phone caused cancer. And the interesting part is penetrance in Jordan is 140% in cell cancer, in cell phones. So it's like people don't even bother on that. So when we started, what we started to do is, prior to thinking of anything we need to do, is we wanted to conduct a truth-telling campaign. Nationwide, talk about cancer, put it on every single part of what we can do within the country. And the first thing we literally did is change the name of the cancer center into King Hussein Cancer Center. And we put the word cancer on every single wall of that building, so everyone that comes through the doors will know that they have cancer. So we can pull that monster out of the cabinet and people face it and understand that, one, it's a curable disease, it can be managed, and it can be done. So at least in this case, we can increase the awareness of that unknown that is present about the cancer. So we've done major campaign in the country, and the major part of that campaign was we were trying to link the word cancer with social norm. So we've done lots of activities all over the country, including festivals, including concerts, including lectures, including anything that links cancer to something very normal or even fun. So the word cancer become normal, and that taboo would be broken, so people at least can start talking about cancer and can start accepting the argument or the benefit of what could happen afterward. We started a national awareness outreach program, and basically this did not only stop on what the Cancer Center and the team of the Cancer Center does, but we went out on specific communities, particularly underserved communities, including refugee camps, schools, and other villages and remote areas, where we started training the trainers of how to educate people on or talk to people about cancer, striking partnerships with communities and organizations, particularly, and with government agencies, and provide access for the navigation for potential prevention and early detection methods. So we did that for almost 1 to 2 years. This is the guy that actually came to my office at the first time. And by the way, after he came to my office, he wrote an article the next day that really slammed the Cancer Center, of how dare the Cancer Center would even put the name of cancer on the wall. So after a year of doing this campaign, things started to change. And many articles started to come out, not against, but with, talking about change in major misconception, talking about people are more open about the disease. And even 2 years later, this particular person, who's really very famous there, came out and say that the Cancer Center was absolutely right. And we must face the disease in an open fashion, and it has to be called cancer. So within 2.5 years, we've changed at least the thought of, well, cancer is cancer and we need to face cancer, and people start talking about it, start getting educated. The participation in the sessions were way higher, and that started to reflect on how people can perceive the thought of, yes, I can do a mammogram because if I have cancer, yes, it's not contagious, and no, I don't have the devil in me, and most importantly, I could be cured. And then that led to the development of a cancer control plan between 2006 and 2007. When we talk about prevention or early detection, the major, and I'm concentrating here on breast, the thought was to really reduce the breast cancer morbidity and mortality through downstaging rather than through mass screening. And the reason we did not put mass screening, because the country did not have the resources for mass screening. It was almost impossible to be able to do that. One, from financial resources, who's going to be paying for what? Again, this is a country without resources, without oil. And second, with a lack of expertise that would be able to cover a population of around 6 to 7 million people. So the main intention was to do downstaging and concentrate on the downstaging. Then afterward, the Jordan Breast Cancer Program started, and that led to putting the mission of that program based on the cancer control plan that we developed there, which include, one, increase public awareness and improve the availability and accessibility of screening services, particularly enhancing and increasing the human resources that exist within the country, and putting a national guidelines for this so at least everyone would follow the same methods that leads to the evolution of larger program within the next 10 years. And it was really building up from the bottom up. So advocacy and awareness was the main milestone of this program, because still lots of awareness need to be done. And I'll show you, the place, again, the cultural impediments are still very embedded within the society. So advocacy and awareness, it has to be a major cornerstone to be able to develop the capacity and the services. So that actually tells you that we're public awareness and education, and then the whole program settled on top of that milestone. And now it's been in existence almost 8 years. You can see some of the numbers, although these are a little bit old numbers, on the clinical breast exam and mammogram. It started increasing within the different governorate of the kingdom. And then also building the capacity was a major tool that needed to be put. So 22 mammograms spread across the nation. Now I think it's becoming up to 35, and the intention is to put it up to 70 within the country. And then 2 mobile mammograms were put there, but more importantly, train of radiologists and radiographers. So again, when we started, there was only 1 radiologist that was a mammogram certified, which was 2003 or 2004, that we sent to Pittsburgh actually to work. Now there are much more that can at least do part of that within the nation. Now, this is a KHCC registry, which is King Hussein Cancer Registry, albeit this is a very limited registry since it is an institute registry, but at least you can see the patients that were seen in that institution between 2006 and 2013, how the stage started to shift. But again, I caution you, this is not the national registry. The national registry doesn't have the stages yet, so this is only a KHCC registry. Having said this, there are lots of impediments there, including the society, the social restrictions, and religious beliefs. So when we look at the stigma, then again, cervix is part of the body you don't speak about. Gynecologic breast cancer may represent symptoms of women uncomfortable even sharing with a male doctor. So couple of studies that were done in the past 4 years showed that family embarrassment, physician genders, male approval, even the religious belief, Allah's wills or God's. So if God's wanted this way, why do I even bother to go and screen? So those are still embedded within the society, and any program has to include those as major part of it to be able to actually succeed. Otherwise, it would be very difficult. So what are the lessons learned? One, address social culture before starting a major national screening program. Second, key opinion leaders has to be part of this. And third, a follow-up is crucial. So workforce, equipment, information, and supportive policies are very important to exist prior to even thinking of building programs. And there are lots of places that programs are being built, mammograms have been put. The problem is that the resources are not there to be able to manage a mammogram, or what happened even afterward. And again, I'm just giving this as an example for breast cancer. The second is sustainability must be considered from the onset, and public-private partnership is going to be extremely important, particularly for financial sustainability. And finally, clinicians should be fully educated in the workforce. Now, if we take this to where we are, and this is why we started with Georgia and Jordan. And in Georgia, we have, again, a tale of two Georgia. We have Atlanta, we have outside Atlanta. And what we've learned from Jordan to put in Georgia, I'll tell you in a second, but Georgia is a 10 million population. Almost 1/3 are minorities, including 30% blacks. 118 rural counties and 18% below poverty line. So when you look at the socioeconomic deprivation index, it's there. Some of you actually live in those areas and manage cancer centers in those areas. And rural-urban classification is clearly, when you look at Georgia, Atlanta is in the middle of it, and then the rest is rural. So when we look at this, we have 50,000 new cases per year with 16,000 deaths. It's very costly to the state, almost $7.5 billion it's going to happen. However, if you look at the numbers, these are the counties in Georgia that actually cancer rate is not decreasing like national cancer rate, is actually either the same or even increasing within the state. It's almost in 119 counties. And the mortality to incidence ratio, anything outside Atlanta is very high, and it is above the national average in lung, colorectal, breast, cervix, prostate, and oral cavity. So because of the time, I'll just skip this one. Having said this, when we looked at, again, when we look at the incidences, we have the population that's very similar to a maybe third world country population. We have in black population always have worse prognosis, 50% higher mortality in Georgian women when they have breast cancer. If we look at colorectal cancer, 42% have higher mortality rate in colon cancer. And if we look at prostate, African American men are diagnosed twice and die 2.5 to 3 times more than white in the state of Georgia. So when we go back to the state and we looked also at what are the beliefs in the state and in that low socioeconomic line, the NCI had put out a report in 2012 looking at beliefs in those areas, North Carolina, South Carolina, Georgia, etc., in certain underserved population and low socioeconomic. And these are the terms that were used in that report. Cancer is contagious, it makes me ashamed, and it's a death sentence. It's exactly the same. I mean, we are talking exactly as I am living in Jordan. So when I went to Georgia, I felt like I'm really living in Jordan again. When we take that further, the common myths, if a close relative has cancer, you will inherit it. People get cancer from, and you can fill the blank, and this is the NCI report, and you have no control over our own cancer risk, and your attitude and belief can help you beat cancer if it works, so you don't really have to bother and do more other things. These are, again, this is a study that was published in JAMA in late 90s. Same thing. This is, again, we're talking about here North Carolina and South Carolina communities. Air causes cancer. Chiropractic can cure cancer. The devil again, because the same thing in a country like Jordan. So when we look around us in where we are, and this is where Augusta is, on this area where our cancer is, If we look only at the counties, and this is where we started a program that's called Seeker, and I'll tell you about the second, in 13 of our counties. It's the bottom 20% of the 159 Georgia county with respect to health outcome. And 7 of 13 are bottom 20% when it comes to health factors, rather weight, etc. So we live in a very underserved, very low socioeconomic class area, which is 51% African American and 24% below poverty line. And some of those rank as 135 out of the 160 counties. So we started a program called CCARE, which is Cancer Community Awareness, Access, Research, and Education. And the intention is to reduce the burden of cancer within the areas that we live in, and then with Georgia and maybe other places. It addresses the cultural and stigma and mythology surrounding cancer. Again, we will not be able to break through this. You know, if you take Georgia, actually, southern Georgia has penetrance in HPV vaccine of 18%. You know, that's huge. We're talking mainly because of mythology and stigma and thoughts. When you know about why people don't get vaccines, I mean, you know, you've heard Michelle Bachmann before, but I think when you go there, there are lots of religious and cultural belief that's part of this. So it's very difficult to break through this without addressing the stigma and mythology, improve cancer knowledge, and expand access to proper service. So, one, we're training the trainer in those communities, provide access to highly qualified prevention early detection services, and assist in the navigation. We're starting this now in 12 communities. 7 are faith-based, 4 are community clinics, and 1 is a community center. And the intention is to, well, what we're doing is we're developing an infrastructure and we're leaving them alone, very sustainable. We're expanding it from 12 to 36 communities within the next 18 months. And then we probably expand it to the rest of southern Georgia to increase awareness, break into the culture, and finally, or the cultural beliefs, and provide the navigation for early detection. We got pretty good funding for this from outside the state, and we're moving forward with it. Now, to go back and re-loop this, we're taking this now also into Jordan, into the Middle East, and we're starting in 2 communities in the Middle East, 1 in Jordan and 1 in Lebanon, to put that particular infrastructure in and try to help that move even forward, to help further the early detection and screening program. Thank you very much.